Myself, Dr. Ramya. I'm a pediatric neurophysiotherapist as a lecturer in Jazan University and a certified exercise physiologist from America. As well, I'm a PhD scholar. So today I'm going to give some true facts about what is the real way of physical therapy treatment is helping the kids with rare disorders. So, um, my case is a 2 year and 6 months old male child who is having a normal prenatal and perinatal history, and the baby has been diagnosed with the pyridoxine dependent epilepsy with a global developmental delay. Initially, the baby has been admitted to the private hospital 7 days immediately after the birth, and they referred to the pediatric neurology hospital at King Fahd Hospital in Jazan, Saudi Arabia. Actually, the caregiver, especially mother and father, noted the baby is having developmental delays. And the key clinical concerns is the baby couldn't be able to sit, and even at the age of 2, and there's difficulty in transitions from lying to sitting, and the baby's developmental age is equal to 7 months. Actually, he came to me around 2 years and referred to physiotherapy treatment for early intervention. For the past 2 years, they couldn't able to handle the baby, especially they want to make the baby to be in a stabilized way, because even a simple change in the environment, he got the epilepsy. So he came to us a reference from the general hospital to our university hospital at his age of 2 years and 6 months. This is the timeline of event from his birth and physiotherapy evaluation. So whenever we are trying to check about the physical therapy development, we first go with the gross motor developmental signs. We check gross motor development, fine motor development, and other developments in kids. What is the importance of gross motor? Gross motor is like baby sitting, rolling, sitting to standing. Like those are called as gross motor development. So for my kid, for my case, the milestones are delayed. Actually, delayed milestones. We see the gross motor development from the birth, since mostly around 3-4 years. For my kid, even it is like 2 years and 6 years old, he couldn't able to roll. If the mother making him to sit, then only he can able to sit. There is no independent sitting, and creeping, crawling not attained, and standing with supports not attained, and baby don't have the independent standing and walking as well. If you're checking the fine motor development, the grasp reflex, yes, the baby attained at 7 months. There is no reaching, there is no releasing, and even mouthing. But baby tries to look everyone else and try to reach them by hands. That's it. Okay. We couldn't able to transfer the objects, and there is no purposeful grasp as well. And what about the language? Since the gross motor and fine motor are delayed, and the language also delayed, the baby turns head to the sounds at 10 weeks only. Baby had cooing at 8 months of his age, and monosyllables and disyllables not attained. The personal social development, social smile, baby attained only at 7th month of his age. Generally, social smile we expecting at 45 days of his baby's age. Recognition of mother only 5 months. Smiles at mirror, image at 1 year and 6 months, waves by 2 years. Physical therapy intervention overview. So what we did for this baby? We planned for a multidisciplinary, tailor-made, especially for this kid. We gave physical therapy management for around 3 months with the frequency of 3 sessions per week, 45 minutes per session. And the home program did 30 minutes daily by using a catalog book. And also we had a multi approach with the OT, and we had a proper communication with the pediatric neurologist regarding the medications and the proper follow-up. So if you could see the physiotherapy intervention, first, our goal is to improve the postural control and stability. What is the real mean of postural control and stability? Because we are aiming for the baby to have at least start with rolling and independent sitting. These are gross motor. So for that, baby should have a good postural control and stability. So the main technique we used here is called neurodevelopmental therapy, also called as neurodevelopmental techniques. So the main intervention is focused on key transitional and sensory motor integration therapy. What does that real means? The baby's transition from supine lying to the side lying, both the sides, then from side to the sitting, Then from sitting to the standing. And if the baby is, we are training in sitting, we are training to reach with the toys. Forward reaching, sideways reaching, posterior, and rotation of trunk. And also, if the sitting activities has been completed, then we'll proceed on to the quadruped activities, especially like all fours, to facilitate the creeping and crawling. And also, we try to improve the baby's trunk control by using the balls, very big therapy balls. It's called as Swiss balls. And by using these Swiss balls and these trunk control methodology in sitting in a small stools, couches, and also trying to transfer them to a balance board, all these making the babies to get the postural stability and control, which is trying to maintain the baby in upright position. So along with that, we are trying to enhance them with the proper reaching activities also, upper limb engagement. What is the real importance of reaching? Reaching and also taking, grasping, all having a proper fine motor skills, which is having an impact over the brain as well. So along with that, we have to complete with the balance reactions and in order to improve the overall postural control. We did for 3 days a week for 45 minutes a session. Second aim is to improve the sensory awareness. What is the real impact of sensory awareness over the gross motor and fine motor? Yes, all the senses in our body, vision, touch, proprioception, these senses are really having an impact in the gross motor and also fine motor. So along with that, we are stimulating the vestibular stimulation in order to incorporate the integration of sensory and motor activities. Once we start stimulating the vestibular by using some planes like, some cradles or like rolling over the Swiss ball, and these are all really promoting the vestibular responses to the gravitational activity. This is the real way to improve the postural control. And also, not only the stimulating vestibular, we are stimulating the proprioceptive position and inputs as well. By this, the activities like making the babies to be in a blanket, we wrap them and we keep them to, rolling, and joint compression techniques. And also we are using the brushes, different types of texture brushes and the weighted blankets, which are all really having a different sensory inputs by means of the joint surfaces to the brain. These are all the ways the baby can get more inputs in the means of proprioception and vibration sense, especially in the vestibular area. Then once coming to the gross motor skill development in specific, we have many activities. We start from prone activities, which is really examples like exercises done weight bearing in forearms, reaching and pivoting, and rolling training. So from supine lying to right side lying, from supine lying to left side lying, even from the prone lying to side lying or under supine lying. All these rolling activity and transitions all be facilitated by using the bolsters, therapy balls. And also we train the baby, go with the supported sitting with hands-free sitting practice and also with some play toys, and we are trying to reaching out to the toys to improve the postural control. For that, we try to improve with the crawling and creeping. So we are going with the quadruped preparation. So we are planning for supported kneeling, rocking activities along with the weight shift in the same position. Then our fourth goal is fine motor and visual motor activity. So along with the occupational therapists, we have our own plans and schedules. It's also NDT and SAT techniques. So we are planning for reaching for toys in different planes, both in frontal axis, frontal plane, coronal plane, like that, grasp and release techniques. Hand-eye coordination also, we emphasize more on these kids. This is also included in the home therapy management. Functional play and engagement, of course, without any play activity, we cannot treat any kids. Of course, we are having all play activity, which is having procedures of cause and effect choice, mirror play for social engagement, and interactive play to encourage vocalization and attention. And the main important one here is caregiver education. Patient education and the education to the parents are very important in the management of all physical therapy terms. Why it is important? Because these activities should be emphasized and re-practiced in the home. Then only the brain is getting a proper way of getting the neuroplasticity because of increased number of repetitions of same activities. So we educated them to mothers' positioning strategies, safe handling techniques, and daily home-based activities, which includes basing sitting activities, reaching activities, quadruped techniques for at least 10 to 15 minutes twice daily, and encouraging the play that reinforce the therapy goals. So if you could see along with the caregiver education, it's coming as like, 3 days of therapy in the physical therapy department, and where mother or father will do 30 to 30 from 20 to 30 minutes in the home. A total of 7 days for caregiver. All the days they will try to engage the baby. And then, so what are the postural things we can see in the interventions? Supine to sitting transitions, standing to sitting transitions, unilateral weight shifts, quadruped rocking and reaching, initiating the crawling, Swiss ball trunk control, standing frame activity, balance reactions through gentle perturbations. So if you come to sensory stimulation, as I said before, we are using the vestibular techniques as a procedural training. In vestibular, we try to facilitate the head nods and turns because we have many different type of swings and balls. We use those things to facilitate this. Gentle swinging techniques and rolling over the Swiss ball and bouncing in sitting. While coming to the proprioceptive facilitation, we are focusing on joint compression techniques and including the blanket rolling as well, and vibration with the textured brushes and weighted blankets with the deep pressure with therapy ball. Then gross motor skill training, as I said before, we are progressing from prone to the standing, prone progression, and from prone progression from prone lying to side lying and rolling facilitations, along with that from side or from the supine lying to sitting, especially the therapy ball, and from sitting in a chair with the proper support, and also making transition from sitting to the standing, all has been done. Fine motor activities, example, reaching in multiple planes, grasp and release practice, eye-hand coordination techniques, and there is always collaboration with the occupational therapist. And we use the play and functional engagement way also. Caregiver positioning. Okay, what is the outcome measure I used here? It's the first only basic measure. It's commonly used for all development delay kids, even for very specific to the cerebral palsy. So here it is called as GMFM score 88. It is called gross motor function measure 88. So it assesses 5 domains, especially lying and rolling domain, sitting, crawling and kneeling, standing, walking, running, and jumping. And really, it is so good and good outcome measure, having a very good reliability and validity in checking these developmental delays. And it's really useful and sensitive for early motor skill changes as well. Results are here. We can see the GMFM score is improved from 14% to 28%. The pre-test is 14% and post-test 28%. There is the greatest improvements in the lying and rolling, sitting and the crawling and kneeling. The meaningful gains in standing and supported walking as well. So if you could see here in pre-test post interpretation, the lying and rolling, here we are focusing mainly the gross motor function. The lying and rolling, the pre-test post, could you see the 20% of improvement? There is an improvement in rolling and transitional control. If you could see, there's a 20% improvement in the better control and trunk and emerging balance reactions. Crawling and kneeling. Standing, yes, it's improved in a tolerance of standing frame. Okay, and also if you're making them to standing with a dependency, yes, he could able to stand for at least 5 to 10 minutes. And walking and jumping, running, with the support, he can walk for 5 to 10 steps and he needs some rest. And really, overall, the gross motor function measure is improved from 4 to 28%, and there is a meaningful functional improvement for 3 months training, especially 3 days per week on 45-minute session. So what I want to insist here is, if you could graph, so if you could properly focus the baby's lying, why the lying and rolling is more important than sitting? Because the baby's developmental growth is just, like around 7 months to 8 months only, gross motor. So that's why our focus mainly on the postural control and stability. Once the start this postural control stability, the baby can able to sit independently. If baby achieve independent sitting with proper balance, only baby can able to stand. That's why the growth and the proper gain is more in the lying and rolling and sitting. So coming to discussion, so the gross motor function, which is quite good tool to check the change in the difference, and there is a measurable gains in the foundational gross motor abilities, and the improvements aligned with the clinical observations as well. The greatest progress is in lying and rolling, sitting, crawling, and kneeling. Gains reflect emphasis on postural control, transitions, and early mobility. So we could able to notice that there is an improved midline head control. Baby could able to use unilateral weight shifting, and there is an increased quadruped engagement, and baby can able to tolerate. And very one important thing I have to note here is, even though we are doing this proper therapy, the baby didn't get any extra incidence of epilepsy during the 3 months of time. They be tolerated very well along with the physiotherapy with the proper medication for this pyrrole-dependent epilepsy. And the baby's sensory motor stimulation and baby's cooing and the activity of monosyllables, bisyllables trying to improve along with the playing activity. And we have to make sure that the progress is consistent with the neurometabolic disorder expectations as well. So the expectation and CP is different, expectation other pace is different. Even in this neurometabolic disorder, the prognosis is good. Conclusion, it's very important. We have to know that early intensive physiotherapy produced meaningful and functional gains. And say, GMFM score 88 is really good in showing the improvements in postural control and mobility and early motor skills. The score is increased from 40 to 28%. And really, I'm trying to highlight the importance of physical therapy and structural physiotherapy in the early stage of the baby in order to get the proper development in the future and support physiotherapy role in the functional independence. The limitation of this is a single case report, and we couldn't be able to generalize it. And it's only gross motor outcomes are measured. And there is no handed assessment for fine motor, communication, sensory processing because we are lagging a speech therapist here. And we're trying to introduce in the future as well. The recommendations should be early referral and multidisciplinary management. The longer term follow-up with repeated assessments. Actually, this presentation is only for 3 months of duration. Hopefully, this kid will come next 6 months. Along with us, baby is trying to planning to go for speech therapy, and we are trying to make the baby to go to the school in the preschool at the earliest, and include the tools for fine motor evaluation and sensory motor integration and communication skills. And it's very important to note that it's maintain the consistent therapy to sustain the goal, not only physiotherapy, and it is essential the caretaker should do the therapy on this program in the home. These are my references, and thank you so much.